Okay, we're gonna take a look at your knee. Okay, first thing we're gonna do is palpation. I don't get a lot of information from palpation, but I get a little bit of information, and if things are really acute, it kind of just gives me a sense of what's going on and how hard can I push on strength testing and how hard can I really examine this patient. So, do you mind if I poke at your knee?
No.
I usually ask consent before I touch a patient, and I just do it very systematically. Start at the top, go around the peripatellar area, medial joint line, anything painful there. Come around to the back to the semitendinosus, no problem. Come around to the front patellar tendon, insertion, no pain. Pes anserine insertion, no problem. Then we get around to the lateral knee, lateral joint line, no problem. Fibular head, biceps femoris, no problem. And our iliotibial band is right up here. And I just come down. Is there any pain or problem when I do that? Nothing to palpation.
No, but that's exactly where I feel it.
That's
when
where
it starts to burn.
When you get it, that's where that makes you stop running.
That's
right.
it right there.
So we're right on the iliotibial band, just past the lateral femoral condyle. She's not complaining of acute pain right now, but this is her familiar pain when she gets it. And so, we're just ruling in iliotibial band problem rather than anything else, like lateral joint line problem, lateral meniscus, LCL, biceps femoris. Nothing's there. It's like this is where it is, and that's great. So we're right in the area, but no pain or problem. I'll do a range of motion screen too. Most people with iliotibial band problems that I've seen don't have a loss of range of motion in the knee, but we'll take a look anyway. Go ahead and just straighten both legs out. Good, as far as you can. Further. Good. Hold that up. Don't let me push down. I've got her here, so I might as well do some manual muscle testing. Push. No problem. Flex both feet up that way. Pull up against me. Good, no problem. Alicia's strong, good. Bend your knees down, good. Pull back against me, good. Bend back, pull back. No pain, no problem. So hamstrings, quads, anterior tib are all good. So I was looking at range of motion of the knee, full knee extension. No need to get a goniometer. Most people with ITB problems don't have a loss of range of motion. I might look at her knee flexion range when we lie down. I do look at hip rotation strength often in running populations, people with knee pain with runners. So let's look at a little rotation in your hip, okay? Just gonna do a little internal rotation. Lower leg goes out. This is internal rotation of the hip. Resist that, don't let me push. And I push pretty hard, good. Internal rotation, left hip, no problem. External rotation, lower extremity comes in this way. This is external rotation of the hip. Good, I support here. Here, go ahead and push up against me. Go ahead and push up against me. Okay, were you trying? The patient was trying. External rotation, left hip. Good, push up against me. Oh, all right. So we see a difference there, right? Did you feel a difference? And very often with my patients with knee pain, if I see an impairment, like I find a weakness like that, I ask the patient, do you feel that? Or I say, which one feels stronger, or which one feels weaker? Because the patient then just starts to guide the eval. Which one felt weaker?
My right one.
The right one, yeah.
Of course.
Okay, let's do that again. Push up against me. Go ahead and push. I mean, she's got nothing, right? So what is an external rotator of the hip? There's quite a few, but really gluteus medius here might be at play. And so we start to think, okay, there might be some sagittal plane kinematics going on, some rotation of her hip while she's running, that's causing a little compression of that iliotibial band. All right, so we've got some strength testing. I'm starting to zero in on maybe there's a hip weakness problem with this, but let's confirm that lying down, okay?